this symposium was an invited symposium by the Scientific Program Committee. I think it's an important topic that we spend a lot of time as spine surgeons thinking about the impact of what we do, both with surgery and without surgery, to our elderly patients. Next, Tim Moore is going to talk to us about the impact of transfer to a tertiary care center.
It's a pleasure and an honor. It's great to see everyone. Thank you for the program committee. Impact of transfer to a tertiary care center. I have no disclosures, none relevant, and my disclosures are in the program. We have an aging population. They're much more active. We got to consider bone health, as Wellington just talked to us about. But we got to take better care of these patients. We got to develop outcome measures and protocols for geriatric trauma. Geriatric population will double in the next 15 years. Greater than 50% of this geriatric trauma is presently cared for at a non-level 1. We have to establish protocols and outcome data. By 2030, 20% of our population will be greater than 65. I'm going to be real close to that, so that kind of hits home. So $34 billion is going to be spent taking care of these geriatric population. There's specific characteristics in geriatric trauma, pathophysiologic changes, comorbidities, and obviously polypharmacy, and these are all things that we need to consider. Does care at a trauma center affect geriatric hip fracture patients? So most centers, regions have geriatric hip fracture protocols. These have been well established over the last 10 to 12 years. This study from 2020 showed there was no difference in length of stay, transfusion rate, complications, time to OR or discharge to home by these centers designated as hip fracture protocol centers. So even in something as not simple as a hip fracture, but as straightforward as a hip fracture, these patients being cared for at specific centers with protocols hasn't shown a difference in these outcome variables. A nationwide analysis of geriatric odontoid fractures, incidence, complications, mortality, and cost. 32,419 patients. In 2003, less than half were getting surgery. In 2017, that percentage almost to 90%. The operative were healthier, so we're choosing to offer surgery to patients who are more healthy, which is reasonable, but obviously that's selection bias if we want to do a prospective study looking at these. The inpatient mortality higher with the operative group. Operative obviously costs more. The non-op is about half the price of taking care of these. And again, 32,419 patients. So I'm going to move into geriatric odontoid fractures now. I'm not going to talk to you about how to treat them. I have no idea. I've been doing it for about 19 years. I'm still as confused as I was when I started. Erica's going to give a great talk on, she's going to answer all of our questions. But 18 years at experience at a level 1 trauma center. The last 42 geriatric odontoid fractures that I treated, the average age was 84, 28 air transports for 42 geriatric odontoid fractures. So we're mobilizing our helicopter service to fly these patients to our center. We were the 4th institution the patient was cared for acutely in 2 of these patients. We were the 3rd hospital in 18 of these patients. We were the 2nd hospital in 15 and the 1st in 7. So we're a regional level 1 trauma center, and we're getting these patients, multiple stops, air transport the night of their injury. And oftentimes they'll show up in the ED, and their 65-year-old son or daughter says, Mom needs an operation. We were told that at the 2 hospitals we visited previously. So this is a real issue. We're spending tremendous amounts of money to care for these patients. And the average was 2.7 CT scans. Now, I know we shouldn't be so concerned about lowering the cancer threshold in these geriatric, but I mean, come on, we don't need to keep re-CTing these patients. At every stop, the patient gets a new CT scan. Because again, if a patient is in an emergency department and they get a higher level study, that doesn't come out of the DRG. So going back to the MRI study before, if you want to get an MRI done, efficiently and quickly, make sure the patient's not admitted to the hospital. In my center, it's almost impossible to get an urgent MRI on a cord injury if the patient's admitted to the hospital. So we're not treating geriatric odontoid fractures appropriately. 17 MRIs were performed, 12 from the ED, 5 from general surgery trauma. I don't need an MRI, okay? I don't need to look at the TAL, okay? But it's just my 18-year experience. So I think we're wasting a lot of money just to come to a diagnosis with these patients. Of those 42, 6 were operative for C1-2 instability. So again, not a lot of expense, and these patients are seeing a lot of providers who necessarily won't be taking care of the patients. 23 total operatives, 7 during the initial hospitalization. So if I see this patient, I don't want to operate on them the night of their injury. I want to talk that family member down saying this is not an urgency. I would rather have the patient, put them in a soft collar, have the patient back to clinic, get to know the family a little bit. If they're functional and they live independently, and I think it's not going to heal, if there's a lot of C1-2 arthrosis, and that's probably not likely to heal, I like to offer them surgery. Oftentimes I get them to 3 months. I do flexion extension. If they move a little bit, I tell them I'm offering you surgery, but I wouldn't necessarily take me up on that offer. I think you're going to be okay. So again, there's a lot of variability in how we treat these. Can we do better? So we've developed a steering committee, 15 practicing ortho and neuro surgeons at level 1 trauma centers. Can pre-hospital care be streamlined to save costs? We've sent out the first round of questions. A lot of you in the room have helped me out with this, so I really appreciate it. We're going to do an analysis, modified Delphi analysis. We're going to try to improve how these patients arrive at the institution that's going to treat them. So this is just an example. You don't need to read it, but it just talks about if a patient is at an outside institution, should the surgeon treating that patient be called before transfer? And it goes into, does a patient immobilize in a rigid collar or soft collar? Do they get air transported or by ambulance? Once they arrive at your center, do we do repeated studies? Do we do an MRI? Do we do a CTA? Where does the patient go if they're going to be admitted? Are they going to go to the ICU? Are they going to go under general surgery trauma? Are they going to be admitted to medicine? So all these things factor in how we care for these. The majority of these patients in my institution spend at least 3 days in a surgical ICU. And it's not necessary, and I think we're wasting a lot of money. And then do we provide chemical or mechanical DVT prophylaxis? Nothing about the treatment, okay? Nothing about the treatment. I think that's one of the arts of taking care of these patients is figuring out which patients you should offer surgery to. But we got to do better in treating these types of fractures. We got to save more money because we're wasting a lot of money. So just in summary, we have an aging population, different factors affecting care. These are unique injuries, especially with geriatric odontoid fractures, okay? Hip fractures, yes, but hip fractures, pretty standard protocol on how to treat them. Do I need to treat every geriatric odontoid fracture that happens in Northeast Ohio? I feel I do and I want to, but do we necessarily need to transfer those patients into regional centers? And do we need to develop a geriatric odontoid fracture protocol? Thank you very much.
And then the comment for Tim is, yeah, I think the transfers are tricky, right? We see this all the time. We see this in our Canadian system as well. So we have a paper right now that's under review at JAMA where we actually show that the transfers independently have an adverse impact on outcome. And so this relates to timing, this relates to discontinuity of care. You alluded to the cost issues. You don't have to repeat a CT scan every time. Like, it's ridiculous, right? So maybe just your comments on that. Like, what sort of protocols are you trying to drive to limit these transfers? Because, it doesn't, sometimes it's necessary if patients are in a rural area. I appreciate that. But in an urbanized area, like in Toronto, we still see this, right, where patients are being managed and they go, oh my God, I don't want to handle this. I'm going to send this to Toronto Western.
We're at the point that we're going to get general surgery trauma involved now. So I'm fortunate that the head of our general surgery trauma is a former past president of the East Society of General. So, we want to establish these protocols. We want, because in Northeast Ohio, we're air transporting patients 3 miles away. I mean, it's a colossal waste of resources, whereas if a patient, Canton, that's 60 miles away from Cleveland, can call the spine surgeon on call, send him a shot. A lot of these are non-unions. They're chronic fractures. These patients can be placed in soft collars and follow up in clinic. And we can't do it as spine surgeons because trauma transfers, at least in the United States, is mostly dictated by general surgery trauma. So we want to get general surgery trauma involved because they don't want to round these patients 3 days in their ICU when they don't need to. And I think it's going to take a multidisciplinary approach, multiple systems to better manage these patients.
Tim, as you were talking, I was thinking, is there an opportunity for using telemedicine here where you can say, because a lot of geriatric odontoid fractures especially, there's no neurologic injury, and can you use sort of telemedicine where you could just have a conversation with the patient or their family to prevent the need to transfer?
I think there's a tremendous opportunity for technology here. The issue is at my institution, which is a county institution, we're not allowed to do telehealth visits because we can't get them paid for. I think there is a huge opportunity for telemedicine and technology. It's going to take some type of grant funding and things like that. But I think that's where the key is. If that, like we said, if that patient 60 miles away, if I could just look at that CAT scan when I'm on call, I'm happy to do it. And then we can not spend so much money in transferring the patient all over Northeast Ohio.
Yeah, Sandy Emery, West Virginia University. Great session. Really a follow-up on what Shiraz just asked for Tim's presentation. So we have the ability for all these little hospitals in the state of West Virginia, which is about as rural as you can get, and the surrounding regions, Maryland, Pennsylvania, even hospitals outside the system, to upload all those images to us. So when I'm on call, I get to call in, I get up and look at it on the computer for the CTs, MRIs that they've done, so grandma can stay in Bluefield, West Virginia, rather than drive up or send a chopper down to get it up to our place. So it is a system problem, and I was going to ask if in Northeast Ohio you have that or don't have that capability of just uploading images so you can look right at them.
We do not have that, and I would say across the country that's a unique system, and I think it's fantastic. But are you called if you're on call for an odontoid fracture? Are you called from the outside institute? That's the first question on the first round of our questionnaire. Should the consulting on-call spine surgeon be called from an outside institution for treatment recommendations for these fractures? So it's great if you're called, but I'm not called at my institution. General surgery trauma controls all trauma transfers and care at my institution, and what I'm beginning to believe, general surgery trauma controls that, from the initial call to the center. But that's what we want to get at.
Thanks.
I'll just add on to that discussion. I'm Amir Abzahi, Vanderbilt University. We have an auto accept that our general surgery trauma colleagues use to make a decision on whether to accept a patient or not. And that includes any patient with a C1 or C2 fracture. So those patients come without us ever being notified. We don't get to make those decisions. They just sort of arrive. I suspect that this is the case in most places.
And again, this is what we're trying to get at, but yes, I think so. And my general surgery trauma team has been conditioned, I use condition as a nice term, but I've been screaming at them for 18 or 19 years that we can't divert any spine trauma patient. So it's more contemporary thinking about these specific fractures.
Question sort of for the whole group. You brought up the paradigm of the hip fracture, the anticipated mortality in the first year following the event. We understand it as a sentinel event in someone's healthcare. And then there's sort of a parallel potentially to be drawn with the age population and cervical fractures. But there's also a difference. Our colleagues have been spending decades trying to figure out how to quickly and effectively fix that fracture. In our hospital, most of them are done under spinal anesthesia. The surgeon is rolling the patient to the PACU by the time we're scrubbing after prepping and draping for a cervical procedure. So the physiologic stress of fixing that hip fracture and what we are talking about doing for a cervical spine fracture are widely different. So I'm just sort of interested in what people's thoughts are about how apt is the comparison to the hip fracture patient versus the group that you guys have all been talking about.
Well, I think as one of the few non-ortho surgeons here, I probably am the least able to talk about the comparison with hip fractures, as I've never, fixed a hip. I think that I'm obviously, junior in my practice, but I presented a couple of those cases, especially the third one, because it has made me a lot more conservative in treatment of these fractures in the elderly. Because when I saw that initial C5-6 fish mouth widening, 3-column, multiple posterior spinal fractures, I assumed, I was taught, this is unstable, this needs to be treated. And I thought, for sure nothing good's going to happen. This guy's 96, he's in this collar, he's going to get intubated for some procedure, he's going to have complications as a result of it. And it actually healed very nicely on its own. So I think, personally in my practice, I have led more towards being more conservative. I love the conversation about frailty, but I think one of the other points was, I don't know if you noticed, but the frailty scores were almost exactly the same for all 3 of my patients. And when I told you the stories of them, there was so much more to their stories. Cardiac disease that has been very stable, even though they're on a blood thinner for the last 5 years, is a different story than the guy who's been hospitalized for 2 months for cardiac failure recently. So even these frailty measures, they're obviously better than just age, but I don't think they're adequately capturing everything about our patients. So, when you do look at the data, though, the mortality rates are really high, whether we operate or not. So, we do need to think about treating these patients if we think that the complications are going to be really bad. And when I do look at the literature, it does push me a little bit more towards thinking, yeah, maybe we should be considering operating on these patients. But then in my own practice, I've sort of had a different experience, and I think every patient's story is more complex even than the most sophisticated frailty index. And I'm sure, all the practicing surgeons here feel that way.
Yeah, I'll chime in. I think, John, your point is very well taken, that these are different interventions, and the implications of both surgical and non-surgical management in the 2 populations are very different, right? In terms of additional morbidity that it comes along with non-operative management. But I do think that there is a common thread, which is the host. And I think you described it very well, that there's nuance there. But if you look at it at population level and away from our individual practices, I think there are similarities that we can carry forward. I think we heard a really good summary of the physiologic and bone-specific issues at play, and it's the same in both groups. The fundamental difference as I sit back is that there are just so many more hip fractures every year, right, than there are cervical fractures in this population. There are extrinsic motivations that have also led a lot of centers to come up with really at least consistent hip fracture protocols, right? These are publicly reported outcomes. And so that also has incentivized the treatment of consistent treatment algorithms or protocols, and we don't have that. So I think what we see right now is a lot of fragmentation, right? We all do it a little different. Northeast Ohio, West Virginia, they all have different ways of managing these fractures. I would love, if we have time, if there are any of our colleagues from overseas, from outside of the U.S., who maybe have a little bit more of a systematic way of addressing this population level. I'd love to hear from them, if not right now, during the meeting.
Well, some of the data, though, are actually really encouraging. What was reflected is spine surgeons tend to be a bit more thoughtful and reserved about surgical intervention in this group. 98 to 99% of hip fractures that roll in the door get fixed. It's rare that the circumstance precludes surgery, but yet the data are still the data. I mean, 20% of them expire. So, I think we're being thoughtful. It's very nuanced and complicated, but it sounds like at least our instincts are leading us in the right direction. We just need to be more scientific about it, I suppose.
We'll take one more question.
Yeah, thank you. Steve Ludwig from Maryland Shock Trauma. My question is for Tim. I know you focused on a lot of the inappropriate patients that were subsequently transferred down to Metro. We actually have the sort of the reverse problem. With the economics that's going on, with the nursing shortages, with our OR resource issues that are not uncommon for everybody in this room, we're often challenged with that trauma patient, elderly, that's sitting at an outside hospital and is waiting. And they're waiting, and we're trying to get them over, but yet they go from a certain magnitude of trauma and physiologic distress to a much more burdensome level of management. And my question to you is, do you have a protocol where you guys say, we can't, you got to get this patient to another hospital, we can accept them, but there's a liability associated with that, your name is associated with that patient? Do you have any experience with that?
Yeah, I don't, when I'm on call, I'm always shocked at what I get called for, and even more shocked what I don't get called about. But oftentimes I'm on the phone talking to treating physicians, at outside institutions, and I don't, at Metro, at my institution, we tend to find a bed for them, whether it be, I don't tell an outside treating physician to send a patient elsewhere. We just don't send patients out. I think, we're a trauma hospital. We're in the middle of huge, wonderful healthcare institution, and, we're considered a regional center. So I haven't had the issue of sending a patient to another hospital. I think that would involve tremendous liability, like you said. And it might be hospital day 3, okay, but we're going to get that patient to our center and treat them from there. But like for this, a bunch of them, we were the 4th hospital that the patient got to at that time.